I speak to you from Genova, Italy. Less than 3% of all the COVID patients had hematological malignancies. I think that they are much more used to preventive measures that are very important for COVID-19, such as strict adherence to hand hygiene, to the mask use, and to isolation.
It seems that there is no difference according to the level of immune suppression in this patient. Rather, we can also speculate that patients who have less competent immune system, those patients can have a less important immunological reaction.
For newly diagnosed patients, it's mandatory in our hands to have a PCR study for coronavirus infection and defer the therapy if the patient is clearly positive. And any patient with fever or compatible symptoms, even without fever, have to be submitted to PCR study.
A general protection against infections and probably also against COVID-19 is the control of the underlying disease. And I think this is really important because it puts clinicians under the pressure to ensure the control of the underlying disease in really very difficult situations.
What we do in our hospital, we give hydroxychloroquine for 14 days. We give it also to patients with mild disease who go home. We provide antibiotic coverage intravenously if a patient is admitted. If they go home, we still provide antibiotic coverage with something oral. COVID-19 patients are prone to risk of embolism. We provide anticoagulants, and I think it's a very important supportive measure as well.
If you look at this graph of the clinical course of COVID-19, this disease is actually slowly evolving. The third stage really is a hyperinflammation phase. And here treatment options would be anti-inflammatory. And steroids are being talked about, JAK inhibition is being talked about, cytokine blockage is being talked about, and 21 patients here had a severe course of their COVID-19 disease, and they've been given tocilizumab the way you would give it in the cytokine release syndrome, and they actually all got better.